Thanks for inviting me to your exciting webinar. I'd like to present the state of play on endoscopic spine surgery in the United Kingdom and some thoughts on future direction. The deployment of any new technique meets a number of hurdles wherever you are. In the United Kingdom, there are about 450,000 spine operations performed every year, which could be undertaken with endoscopic spine surgery. Currently, the provision is about 85% in the National Health Service, 15% in the private sector. However, the first hurdle is NICE, the National Institute for Clinical Efficacy and Excellence, but most of us think that that should actually read economy. And they base their permission, their sanction for procedures to be performed in the NHS on the completion of randomized controlled studies. Whilst the private sector, of course, use their local ethics board, and training of the surgeons is at their own cost. The provision of money follows the guidance of NICE and is performed by local commissioning groups, whilst healthcare chains look at individual procedures as a matter of opportunity. And the hospitals in the NHS receive their funding from the commissioning groups, and they won't receive funding for new techniques until NICE gives their sanction. And equally, the training is inhibited by the same limitation of funds, whilst the private sector see a financial profitability and move ahead and provide. So when looking at the timeline that it takes for a new surgical technique to be implemented, the evolution and development of instruments requires 2 years. The prospective studies with recruitment, conduct, and publication require 5 years. The randomized controlled study funding or fundraising takes 2 years. Pilot study, 3 years. And then the multi-center rollout of a randomized controlled study to point of publication takes 7 years. And then the National Institute of Clinical Excellence takes 2 years to evaluate. Total duration, 21 years. And they may ask for more randomized controlled studies. The overemphasis on provision of a full evidence base defers clinical savings, such as the lessening of complications, the provision of day case surgery, less analgesia, and less revision costs. Training is deferred because the hospitals aren't funded, and fear of litigation because the technique is deemed to be experimental. The social benefits of reduced preoperative social care, community costs, and GP costs, and the labeling of the technique as experimental inhibits all progress across the board and reduces the provision of advanced techniques. But all is not lost. Although being an island community, we have conservative attitudes, endoscopic discectomy is being undertaken, but very limited amounts of foraminoplasty. Endoscopic training and rotations now exists in our major spinal units around the country, and their results are replicating existing reports. So my future aspirations are that there should be greater dissemination of cluneal nerve trigger point awareness and radiofrequency treatment, increasing use of laser foraminoplasty and failback surgery, the combination of non-reactive resorption hydrogels with stem cells to restore nucleus function and annulus integrity, and ultimately the use of adenovirus vectors to take messenger RNA into the cells of genotype vulnerable adolescents, which then activates when degeneration commences. So long may spinal surgery in an endoscopic form expand and develop these new techniques. Many thanks.